series, GI series, of upper gastrointestinal series, so upper GI, UGI, OOGI, so text will refer in different ways. Okay? So there are different ways of calling it, but they all mean the same. All right, and this is what it may include, and it depends on your X-ray department. Not every X-ray department, not every radiologist will do it in the same way. So typically it requires a scout KUB, all right? You do the scout KUB to see what you take a look and see what you see without any contrast media. A lot of times you can see masses, you can see fecal matter. If the patient didn't follow the protocol and still has a lot of fecal matter there, the radiologist might decide to postpone the exam and send the patient back, give him more laxatives and more enemas until the patient's clean. So it's important to do the KUB. And then you will do a fluoroscopic and serial radiographic studies of the esophagus, stomach, and duodenum using ingested contrast media, usually barium, but it can be iodine as well. So even though it's called an upper GI series, you will think just the stomach, but it also includes at least one picture of the esophagus, the stomach, and the early portion of the small bowel, the duodenum at least. Okay? So that's what I'm saying here, esophagus, stomach, and duodenum. When requested, the barium may be imaged as it transverses the small intestine. A lot of times they will say, okay, we see what we need to see, but let's wait a little bit. Let's wait another 20 minutes. Let's wait another half an hour, and wait until the contrast media has moved throughout the small bowel. Okay? If that's the case, then the exam turns into an upper GI with a small bowel series. Okay, and I'll talk about specifically the small bowel series in just a bit. But let's do the upper GI first. All right, patient preparation requires stomach to be empty. Okay, so no food. A lot of times patients need to take their medication, and it depends on the doctors how they want to handle that. Okay, but ideally the stomach should be empty. It's desirable to have column free of gas and fecal matter. That's why the KUB is called KUB. Food and water are going to be withheld between 8 and 9 hours before the exam. So nothing to eat. So that's what they call it. NPO, nothing per mouth. A lot of times people will say, can I drink water? Nothing. There's nothing, right? NPO, nothing per mouth. That means you stop water, you stop, that's what upper GIs are typically done early in the morning. Start doing them at 7:30, 8 o'clock, by 10 o'clock, typically it should be done. We don't see as many upper GIs, we don't see as many barium enemas as we used to. Nowadays you might see maybe 2 or 3 a week, maybe 1 a week, because CT can reveal a lot of information. Okay? Ultrasound can also do a lot of what we used to do with upper GIs, but we're still doing. You're still responsible for it. You're going to be tested on it when you take the national board. Even though we don't do, the volume is not, just to give you a sense of how many. When I worked at South San Francisco Kaiser in the mid-80s, late 80s, we used to do, on the average, I will say we used to do 10 upper GIs. Every day. Average. Sometimes we have 15, sometimes we have 8, but on the average, about 10, 11 upper GIs every day. We used to have 2 rooms going full blast. 2 fluoro rooms, just getting them out. Like I said, nowadays you probably maybe see 2, maybe 3 a week. You don't see them that often. Once again, because there are other modalities. But, what I'm trying to say is that you want to do it early in the morning because the patient has been fasting for 8 to 9 hours. And patients are hungry, patients get cranky. They do. And it's something you have to understand. What happens to you when you don't eat for a few hours? You start getting really upset. I don't know about you, but I do. I do get cranky. I do get upset, and I want my food. I do. I can go maybe 4, maybe 5 hours without eating, but by the 5th hour, I'm upset. I don't know if you've seen those, what is it? Those chocolate commercials, the Snickers commercials. So, patients will be like that. Patients will turn into somebody else, and they are gonna get very cranky. And you have to understand, patients have been fasting, and so be kind to them. Might not be their typical personality. It's just that, not only you're there fasting, but they give you this gown that doesn't cover anything. The place is cold. You see people going in and out. You see people that came after you and they go in the room and they leave before, because they don't understand that you're doing chest x-rays at the same time you're doing other exams. And you see all these people, bunch of people that came half an hour after you, and they are going and you're sitting there. And so you start getting pretty antsy. And so understand that. Be kind to them. Okay?
But don't give them a Snickers.
Don't give them Snickers. Don't give them Snickers. Yeah.
Snickers or
If it's small intestine.
Snickers.
Yeah, if the small intestine is examined, food would help the following the evening meal. So nothing after last meal, and typically that meal will be a light meal, maybe I don't know, some tea, something very light, very, very light, something that is not going to create a lot of gas or fecal matter. Okay, something just light. All right, and so they're going to be even more upset. If they smoke, you need to tell them not to smoke. Why is that? Because when you smoke, gastric juices also start moving. Okay, and so you don't want that. No nicotine or gum are thought to stimulate gastric secretion, so these are often restricted for the same time. Okay, so now you have a smoker that smokes, 3-4 times a day, or I don't know how many a day, and now you tell them you can't smoke, they are gonna be really cranky. You're gonna be very upset.
Oh,
okay?
Yeah.
So just think about that. All right, so the GI series. So single or double contrast can be done. Okay, double contrast includes barium and gas-producing substance. So powder, crystals, pills, carbonated beverage, all of that will do that. Okay, the point here is to get gas in your stomach. Okay, or like I told you the other day, you can put, what we used to do at South San Francisco Kaiser, on the straw we used to put a needle, and so when the patient were drinking the barium, they were also swallowing air, and it works really well too. They were back then, the radiologists, they avoided the seltzer, the pills, because sometimes they went really far, really extend the stomach, and can give you a lot of pain, and so that's how they used to do it. You can also do biphasic examinations, where you start, where you do a combination of single and then you follow it, or the other way around. You start with a double contrast and then you follow it with a single contrast. So you can do both, and those are called biphasic examinations. But it's the other way around: combination of single and contrast, double contrast. The double, you do the double first, where you coat the lining of the esophagus, the lining of the stomach. You take pictures, and then they will have them drink thin barium, and then you fill the stomach with barium. Okay, and then you give them more air, and so you can remember the thick barium. What is the purpose of the thick barium?
Absorb the
To
extra.
coat the lining of the stomach and the esophagus. Okay, that's the purpose. All right. Usually begin with the patient in the upright position, if possible. A lot of times patients won't be able to stand, but if possible, upright. Okay. Radiologists may examine the heart and lungs with fluoroscopy if determining the tongue. To determine that the stomach is empty. Okay. Radiologist instructs the patient to drink cup of barium. So the first thing, you get the patient ready, get the patient in the room, get the radiologist will come in, and you will do the fluoroscopy part first, and then you follow it with the overhead pictures, usually. All right, esophagus is examined with the first 2 or 3 swallows. So the radiologist, you have the patient on the table, last drink, and, they look at it under fluoroscope, and they can move the fluoroscope up and down to see how the barium moves down the stomach. Okay? If necessary, and then it will feel the stomach, then at this point, if he or she feels it necessary, he or she will take pictures. These are called spot films. All right, let me explain. Not too many people do this anymore. A spot films refer to actual pictures. This is the radiologist has the capability of switching from fluoro to radiographic mode. Okay, so when you take a spot pictures, he turns off the fluoro, and this is very quickly, not the whole machine off. It just switches from fluoro to radiographic, and he takes a picture. But this is a radiographic picture with a different technique. Take a picture, and it looks more like a regular radiograph. If you do it with fluoro, if the picture is taken with fluoro, it looks too grainy. And so it's because of quality of pictures. Are you following me?
Mm-hmm.
All right, so the spot film is taken under the radiographic mode.
Okay, it's the fluoro.
You still use the fluoro too, but you switch it. Okay. All right, you switch it. The technical factors are changed. In fluoro, okay, you're going to be using. Well, let's leave it at that. Next time we'll talk about it. Just remember that when we talk about spot films, the doctor has switched that mode and it goes to radiographic mode, and it takes seconds. It takes a picture, goes back to fluoro. Okay, and it's even using the image intensifier. He's using the tower. Are you following me when I say tower, image intensifier? To even get that, to capture that permanent picture, that regular picture, all right? And that's why many radiologists don't want you to do overheads anymore, because the quality of the images nowadays are good, really good. There's no need for you to do extra pictures. Are we all right?
Mm-hmm.
Okay, okay, good. All right, yeah.
Is it the same thing when you press save on the fluoro, that
Right.
spot?
And have you seen that when they are doing that, you see this bright light?
Mhm. That's the picture.
That's the picture.
Okay.
See, they stop the fluoro for 2 seconds, and then you see this bright light, and you see the screen just lighting.
Mhm.
That's the permanent picture.
Oh,
Yeah.
okay.
Because when you say save, they can also go back to, if they are recording the whole exam, if they are recording the whole fluoro case, they can go back and save different frames. They can do that, but the quality is not as good as when they are doing spots.
Okay.
Okay. Yeah. Manual manipulation used to cause gastric mucosa. So what they will do is have you seen that? Those of you who have done fluoro, have you seen a paddle that looks like a racket and it has a little balloon in the middle?
I
No.
don't think so.
Okay. It's a thing that kind of looks like this. It looks like imagine this is round, and you have a balloon in the middle, and it has a paddle, right? And so they will bring this paddle, okay, which is radiolucent, and then they inflate the balloon. There is a little pump here, okay, and they squeeze it, inflate the balloon, and then they can put this paddle, and then they press on the patient so they can help the barium move around, okay? It also helps in spreading some of the tissue around it, okay? So that's what I'm referring here as manual manipulation used to code. So don't think they stick something and no, they on the outside they will manipulate the barium to move the barium in different locations of the stomach. All right, patient drinks more barium to fill the stomach. Okay, you give them almost a full cup. Okay, they drink this barium. All right, fill the stomach, and once again, more spot films are going to be taken. And so take a look. See here, for example, the stomach is pretty full. Barium, once it gets in the stomach, because of peristalsis, it begins to move. And as it's moving down, it's going into from the stomach to the duodenum, and then you can observe the duodenum and part of the ileum. In this case, they're showing you there is something going on here. See, coming here, and something is not filling with barium. And see how well defined it is? Something is going on here. Some type of mass. Something is there. In this case, a peptic ulcer, hiatal hernia. A lot of things can be diagnosed with this. Diverticula, gastritis, tumors, Bessoir. I'll explain what all of those are. Okay. Here's what a peptic ulcer looks like. See this thing here? That shouldn't be there. So that's a sign of a peptic ulcer. Hiatal hernia, take a look. This is the stomach. Here's the diaphragm. Now, a portion of the stomach has gone out into the diaphragm. All right? So, that opening in the diaphragm has, the stomach has maybe, I don't know, for whatever reason, it's just a portion of the stomach, a portion of the fundus just went up. A lot of times, even intestines can go up. The problem is that it creates a lot of pressure on your chest. Lots of pressure. Patients eat and they feel like they are having a heart attack. And so it can be surgically repaired, but it is a problem. That is something you can see. Take a look. This is Bessoir. Bessoir is when you will be demonstrated when when barium is not really coating the stomach, and so the stomach lining has been damaged. Take a look at, pull out your medical dictionaries. You forgot all about it, huh? It might be on your next exam. What is a Bessoir? Well, you look it up at home.
Collection of hair. Can be a collection of like hair and other stuff that you
Yeah, and in this case, let me go back. Where is it? It is just the lining has been damaged. It's just so damaged that is, why, different reasons why. Take a look. This is a big diverticulum. A lot of times people think diverticulums can be small. What I just referred might be, I said something going on here. A big diverticulum there. Okay. A diverticulum is just a pouch that comes off typically intestines, but it can be in anywhere of the digestive system. It's just a pouch. The problem is that a lot of times food content can get in there, and a lot of times it doesn't come out, just like the appendix. Okay, goes in, doesn't come out. What happens when you have food in there for 3 or 4 days? Decomposes, right? And then you begin to get an infection in there. Take a look. Hiatal hernia, a little bit here. Let's move on. In this case, they put a Shansky ring. Is that thing they put there so things won't go back up. All right, here's a rugal folds. Look. Okay. Absence of rugal folds. You have rugal folds, and then you have something else going on there. Type of little mass there. So a lot of stuff that you can diagnose with this. Projections that are going to be done for the upper GI, guys. The REO, and typically remember, you're going to include at least one projection of the esophagus for most radiology departments. So you're going to have an esophagus, typically an REO esophagus, but then an REO of the stomach, then the right lateral, an AP, an LPO, a PA, is typically what is done. You can have less, you can have more, but a typical, and that's what I'm saying, a typical upper GI studies will include these 5 projections. In addition to the SCOUT KUB. For all of them, the distance will be 40 inches. Shielding, it could be possible, especially gonadal shielding. A lot of times though, because you're having the patient turn around, especially if you're in fluoro, you turn them around, move up, move out, so the lead shield can cover them. But for the overheads, yes, you can use a lead shield. Okay, the pictures that you're doing, not during fluoro, but the pictures you're doing with the overheads, you can use a lead shield. Okay, collimation, yes, you collimate when possible. Now, don't try to collimate and end up cutting off the anatomy of interest, because then you won't have to repeat the x-ray. And so collimate as much as you possibly can. Let's stop here. I need to return your exams. And so